Top Med Talk.
Welcome along to Top Med Talk. This is part 3 of a 3-part series on perioperative anaemia. Taken from one of the key moments during EBPOM London, it's co-chaired by Mike Grocott, Professor of Anaesthesia and Critical Care at the University of Southampton, and Rachel Barlow, National Lead, Enhanced Recovery, Prehabilitation and Optimisation at Cardiff and Vale Health Board in Wales. Facing questions, we have Scarlett McNally, Deputy Director for CPOC and Honorary Clinical Professor at Brighton and Sussex Medical School and Consultant Orthopedic Surgeon in East Sussex, and Jamie Plum, a consultant in Southampton, finishing up his PhD, which just happens to be about anaemia in a perioperative setting. Don't forget to check out the show notes for the outstanding parts of this series. You'll be able to find them linked to there. And of course, don't forget to subscribe to Top Med Talk.
So I'm Zoe. I'm actually an OT by background, but I've been involved in the prehab cancer delivery. And one of the biggest problems we've been having, because we've got 10 different acute hospitals involved across Greater Manchester, is that complete inconsistent approach to iron in cancer care pathways. And I'm just thinking, with the ICS is coming online as of Friday, and with this brilliant guidance coming out, having these conversations within local clinical teams doesn't feel really necessarily the right approach. I'm just wondering what we can do in terms of a more system approach with the ICSs, with the cancer alliances, to try and really implement these guidance, because, we're kind of fighting a losing battle if we're kind of doing the exercise, et cetera, with the patients, but then we haven't got the medical optimisation bit right.
As always, Zoe, you hit the nail absolutely on the head. And I can see my colleague here, Ridian, who leads the prehab team in one of our areas. And basically, we've had this conversation recently, haven't we, Ridian, around tertiary referrals, who's responsible for the, dare I say, the IV iron infusion, whether, but this is for cancer now. And I think this is absolutely such an important part of care. And it's who is responsible for commissioning that service. In Wales, as they do in Scotland and Northern Ireland, we have health boards. So each health board is responsible for their residents' population and health. So technically, it's the health boards that are responsible, not the tertiary centre. So it's a minefield. And we're just about to start unpicking some of this with our regional collaborative. And anaemia is one of our big hit winners because we know it can make such a huge difference. I mean, the beauty of the work is if you start in primary care at the point of GPs, then some of this falls out as being irrelevant. Not the IV iron infusions, clearly, but if you can start oral iron at the point of referral via the GP, then that can obviously play through with adequate time. So, yeah, I think that is just such an important statement and question. I think it's for Scarlett, really, on behalf of CPOC. How would we tackle that?
What we've been trying to do with CPOC is get the guideline out there, and it's so readable. We haven't got an executive summary, we've got a lay summary, just because actually this is something that we've got the complicated educational bits about Hepzid and up-down stuff. But basically anybody who sits down and concentrates can read it, including people that manage health services, and realize how it's important. It's surgeon-proof as well. People can read it and understand it. It's not like, that bit you have to go on a hyperlink and get. We're hoping that people will be able to build their own things. But there was a big quality improvement in anemia study, Quist anemia, and they found that you have to have individual places having their own pro forma for what they use, because that's what they've developed over the years. That's what works for them. You can't just say, right, everybody stop doing that, and you've got to use page 27 photocopied for your thing. That doesn't work. A lot of people are a lot of the way there already.
I think the point that Zoe's trying to get to, though, is around maximise the benefit of prehab through anemia. So it's actually the lead-in time, because we know the efficacy of exercise can be maximised with, I think that's what you're getting at, isn't it? In terms of commissioning of prehabilitation and making sure that the patients aren't going to, dare I say, fail with their exercise prescription because they are iron deficient or B12 deficient anemic.
You have to dangle right back to the moment of contemplation.
Exactly.
If the blood tests are done early, admittedly they don't always pick up everyone, but if blood tests are done early and then the follow-up blood tests to check what type it is are done early, then you can have all that thinking going on while they're getting ready. The waiting list is preparation list.
Is there any other comments?
Next lady in pink, she's waiting very
sorry.
So I was going to ask about the phosphate question, because our gastroenterologists are very excited about this, and obviously they've got more chronic iron requiring patients than we do. And I noticed that it made it into the NICE guidance for blood transfusion briefly, and it's been taken out again. How worried should we really be about following up phosphate levels in patients?
You're talking about people who've had IV iron, yeah?
Mm-hmm.
Yeah, so this is a thing. This is definitely a thing, okay? So if you talk to the IV iron reps, they try and play this down. This is a real thing that happens. So you do get a dip in phosphate levels at about week 4 to week 5. Nobody knows the significance of this. There are a few papers on it that have tried to ascertain, but it's quite difficult to tease it apart. So you have a low phosphate and you don't feel very well, but actually you've just had a big operation or you've just had all this stuff. It's very, very hard. It's like length of stay. You could pluck it out of the air. What's the cause of length of stay? I don't know. I don't know the answer. It's definitely a thing and it definitely needs more research. That's all I can say on that.
And what do we do when we see a low phosphate?
Nothing. So we don't measure it. It's only been picked up. I don't actually know the history of how this was picked up, but somebody in one of the trials looked at phosphate levels sort of post-iron. We don't really even understand the mechanism, but it is a thing. It may be significant.
I think it was picked up with the gastro patients having repeated.
Yeah, like the Crohn's group. Yeah, I think the renal physicians have been onto it for some time, but the significance, someone else may know more than me about this. The significance, I don't know.
There's somebody here at the back of the room with a hand up. Do you know the answer?
Sorry, this is total anecdote, but a colleague and friend received IV iron as treatment for menorrhagia, not preoperatively, and almost had to be admitted for IV phosphate. And she's 3 months down the line still taking oral phosphate after a single 1 gram dose of IV Ferinject. She only found out about it because she was doing the perioperative master's degree and somebody else gave a presentation about it. But she was really ill and she was instantly better with phosphate. Again, yeah, the GP and the drug company made very little of it, but definitely a real thing.
I wonder if you could comment a bit more on post-operative IV iron or immediately pre-op. And I'm thinking particularly the patient who is iron deficient but not anemic.
We use it. Yeah, we don't have the data to support it yet. There's trials ongoing at the moment. And Ian Moppett's looked at it in Nottingham. Yeah, I mean, logically and sort of sensibly, if you would have treated that patient 3 weeks ago, if you'd known about it, why not just treat them then? The only downside to that is if they are septic or there's some other risk factor where you may not want to do it. I think the key thing is just consent and the patient wanting it and being on board with the possible benefits of it. And as long as that process is gone through diligently, I don't see any reason why we shouldn't be doing that unless we have some data to say otherwise, which we don't currently have. But we do it.
How's the lady at the back with the...
I'm super keen on iron anemia, but I just wondered, in light of the PREVENT results, what are your thoughts about anemia really just being a marker of disease severity and non-modifiable?
That's a really good question. So Rupert Pearce's group kind of commented on this quite a lot after the ESOS data. They did a big study after that I think Juliet Barron was the lead author on, and they posed the question. We don't know the answer to that question. Nobody can eloquently answer that question in 2022. There's definite elements of both, yeah? So if you have loads of multi-morbid chronic diseases, you're more likely to be anemic. Okay, that's a fact. Is it the anemia in and of itself that's causing the problem, or is it the other diseases? That's like my number one question I'd like to answer. So, because I think that if you're really, really anemic and you're otherwise well, that your ability to perform, aerobic exercise is diminished. And I tried to look at that in one of my studies and we sort of found some data that supports that, but it's really small numbers, so I can't hang my hat on it. I'm like a believer in that, but I cannot say with any level of confidence that it's true. So we don't know the answer to that.
A lot of it's about inequalities in health and social deprivation and poor diets and poor education about nutrition and all sorts of things, and how much of that is modifiable. I personally believe a lot more is modifiable than we realise. I think people and their families can adapt their diets, but they just don't know how to at the moment. Yeah. And in the papers, as I said, we've looked at some of the numbers I put on the slides. The risk with anemia, you've got a risk of complications about 3 times greater. But as an independent risk factor, I think looking at all the things, it adds about 20% extra complications. It's that sort of order of magnitude, probably a lot of it.
Yeah, that's related. Pretty much what the ESOS data showed. It was around that figure. I think that was the first time actually that had been drawn out as an independent risk factor. If you look at multivariate analysis in that paper, it does show, but you can't say it's cause and effect still. I believe it, but I don't have evidence to support
there is intervention studies. Some intervention studies show it does help, particularly in the anemia guideline on pregnancy, that it does help reduce the bad outcomes of pregnancy if you treat anemia.
My interest in the colorectal functional iron deficiency group, which are the ones that I deal with, there didn't seem to be any answers yet for that group.
I mean, your point on causation seems very well made, and none of us can say we know for sure whether it's reverse causation. It's confounded, but the compelling thing, I mean, there's a health economic argument on the basis that it seems in practice you can reduce transfusions. Yeah. But probably more importantly, if the patients definitely feel better, having less fatigue, less breathless, having had iron, that seems reasonably compelling. And that comes back to, we can have a shared decision-making discussion, explain to them, we don't know for sure this will improve your overall outcomes, but you're probably less likely to have a transfusion and you probably will feel better. That's probably where we're stuck at the moment, I guess.
Mike, there's just a few comments here on Slido I'd like to read out. Someone said, I had anemia diagnosed 2 weeks before a major spinal op. A pre-op anemia service would have enabled optimization, prevented cancellation, and enabled prehab. So I think that's a really important statement. Comments here around, does it go back to the comments made in earlier sessions today about completing preoperative assessments earlier so interventions can be implemented in a timely fashion? So I think that's what CPOC are advocating, aren't they, Scarlett, around that early detection, making sure that we can instigate remedial treatment in a timely fashion.
Absolutely. And there's some I think it's difficult because the system is set up as pre-assessment being to get you through the operation rather than so many months in advance to get you ready and prepared for an operation later. I think my view is because people don't want to have to redo it and they want to do it when the blood test hasn't run out or, expired or something. But we do need to do it earlier. And some of it's around if someone's going for a CT scan and they have to have renal tests before they're allowed to have contrast, while the needle's in their arm, take a hemoglobin as well, or the other tests as well. It's identifying who's highly likely to do it and just getting the tests off early. And then you've got the thinking time as well as the treating time.
That's the whole hearts and minds thing that I think your colleague over there is talking about. Is in the MDT setting, in a regional basis, you have these patients at diagnosis. They are having a renal function for their contrast CT. They are having that. That's just accepted practice. They need to have their hemoglobin done at the same time. And it's the oncologists and the nurse practitioners and the surgeons. You have to get them in a room and you have to change the culture of that. It's really hard work, but it's doable. And they have to understand why this is worth doing.
Just a quick question. Sorry, Zoe.
I was just going to say, our colleague this morning from Holland was talking about endoscopy, taking blood, the next day starting anemia management. And I was involved in the OG best time pathway work last year. And I was just thinking, that would be fabulous. But again, that requires, it's the commissioning element, it's a system approach, because actually, regardless of whether someone's going to then go on and get a diagnosis and go for surgery, actually, if they're anemic, they need the management regardless. If we could do it at that point, 100%. But it's again, how you implement that in a pathway. Just knowing what it can be like to get.
Not all the people who come through our service have surgery. Absolutely. That's not a prerequisite to being treated at all. Most of them do.
We're going to have some real challenges because anemia being an example, but there are lots of ways you can help people exercise. So Sandy Jack's data this morning suggesting that with psychological support, there appeared to be an effect. It was less marked without. But I mean, the same is going to be true of an improved diet in almost any way, of a bit of anemia support, of stopping drinking, of not smoking, et cetera, et cetera, et cetera. And it's going to be very hard to tease out those incremental improvements in randomized controlled trials. Even the trialists are going to get bored of that. Yeah.
I'll come to you in a minute, really. Just want to quickly answer, if you could just answer this very quickly. Do you treat non-pregnant women with HBs between 120 and 130 in Southampton prior to major surgery?
Yeah, absolutely. Yeah.
Ridian.
Just on picking up anemia early, in our hospital, we do, as soon as you're diagnosed with a cancer on endoscopy, the colorectal nurses will come to endoscopy suite and take all the bloods in and refer for CPAP at the same time. So actually, it's quite an easy process to put in place. If that's, I don't know how it's set up in other hospitals, but
that's what we do.
It's very straightforward for us. So we know that every person arrives at a CPAP clinic having had all their blood and hemoglobin done.
Oh, there's a question here.
Did you want to show your
you were saying about doing bloods early when you book the case. is there a case for giving, say, supplementary iron at the time of booking, particularly for those cases where we were considering major surgery, which we find is a blood loss of greater than 500 mils? Because many of these patients may well not be anemic, but they'll be anemic post-surgery. So shouldn't that be part of the pathway? So we're actually not only detecting people that are anemic, but we're also anticipating a post-surgical anemia.
Yeah.
And you said about the symptoms afterwards.
Yeah, I mean, we absolutely do that. It's a bit case by case, and if they're not anemic at all, but they are iron deficient, it is a bit case by case. But yeah, we're doing it more and more. And that my colleague who runs the service now is a big fan of doing that, so she will put them through anyway. We don't have hard evidence to support that practice, as we've kind of alluded to before. But as you say, if they're having, a massive liver resection or a scoliosis repair or something where they are going to bleed, 100%. They will drop the hemoglobin at day 7, day 9. They'll be hanging around below 100. Then, it seems logical. As I said, we don't have the outcome data to support that practice, but it seems logical, and that's what we are doing.
Does anyone have hematocue point of care test, HB test, in their surgical outpatient department to test patients at the time of booking? Seems like a no-brainer, and that's from Joe Coates.
Hi, we run that in our pre-op clinic so that when the patients come through, we'll do point of care testing. HemaQ, unfortunately, is going out of business and is not supporting their hardware anymore. So we've had to introduce a blood gas machine, but it allows us to check if our major surgical patients are anemic, and then we automatically request the follow-up bloods at the time so that we can potentially then do same-day IV iron if necessary.
We're very lucky in the sense that ours have already had theirs before they come to pre-assessment, so we don't need it. We did look at it at the time, and we thought this was going to be a really good idea, but we get them, as Ridian was describing, at a much earlier bit in the pathway. So not always, we miss them. I mean, the classic ones we miss are the tertiary referral ones. So the HPB group who bowl up from another hospital, they've been worked up elsewhere, they come to pre-op clinic and they're having their operation tomorrow. It's frustrating, but it's like everything, it's a work in progress.
Yeah. Microphone right there.
I was actually going to ask Jamie, and I was interested in the audience. We've had some issues, as you know, locally with our HPB surgeons being very concerned about the impact on the liver of IV iron near to the time of surgery. Do you have any thoughts about that? And I'm interested to know if anybody else has come across HPB surgeons who are very happy, because ours aren't.
Yeah, we've talked about this, haven't we, briefly? I think that if you're wedging out a small tumour, laparoscopically from one segment, it's probably a non-issue. If you're taking most of the liver out, it might be an issue. I don't know the answer to this at all, and I don't think anyone's properly looked at it. I'm not aware of any good literature on it. It's definitely, again, another thing that probably wants looking at. So we're talking about the safety of a big iron load to a liver you're about to chop out that inevitably is going to potentially struggle anyway. Is that actually doing them a disservice or not? We don't know. We initially were treating them, then the surgeons. I don't actually know where it came from, if I'm honest. We need to probably find out where the twitchiness came from, but possibly somewhere. So if anyone knows the answer, I'd love to know the answer to that.
Just again, a comment here from Slido, and I think we're all very much in this space already, is should we be now changing the mantra of waiting lists to preparation lists? And I think, again, this is something certainly we've talked about in Wales for many years, and I think, colleagues here, and, I think absolutely yes.
Can I just say there's quite a lot of information for patients on our website. Admittedly, that gets the patients who are interested, but cpoc.org.uk/patients. It's got the fitter, better, sooner resources from the Royal College of Anaesthetists. It's going to have all the patient information on anemia, nutrition, that kind of thing, because it's what people can do for themselves. In orthopedic surgery, there's a charity called Versus Arthritis. That's got some really good resources about exercises you can do when you've got arthritis and how to help yourself when you're on a waiting list, and pain management, and trying to reduce opiates before surgery because you have a better outcome afterwards. There's all sorts of stuff out there, but it's how to get people to realize they're not passively being passive patients, and that it's not an inevitable, unmodifiable thing. It's as if you're an athlete. It's the little gains. Yeah,
I think that was what came. I made reference to it earlier about the nudging work that we ran in COVID, and I think the big thing was about small. And I know we quoted it a lot in ERAS days, aggregation of marginal gains. And this is exactly what we're talking about here, isn't it? It's about the small quick wins that the patient and the person can do for themselves, but they need to be prompted and reminded. Yeah. I'm a strong believer we don't know what we don't know, and we assume people know, but they don't actually know. And I think that's why the guidance is so perfect, because it's got that lay, standards of care for the individual and their families. I think that's what makes this guidance stick out for me. We assume people know, but they don't actually know, and sometimes you've just got to spell it out, really.
So, Rachel, I know you had a couple of slides. Have we covered most of that ground, or do you want to show those?
I'm always happy to talk about the primary care, secondary care interface work, Mike, but I can show
we've got a couple
2 minutes.
One issue,
we had some fillers just in case we ran short, but actually...
That's one I want to come back to, but why don't you show those briefly?
Yeah, no, I'm happy to do that. Sorry, I'm Rachel Barlow. As I say, I'm passionate about starting preparation early in the pathways, and I've been working on this for since ERAS, basically, 10 years ago, when we found that people are being cancelled within 48 hours of surgery for things that could have been prevented way downstream in the pathway. And often these things could have been detected by our primary care colleagues. So we're in South Wales running a system-wide approach to pre-treatment optimisation and prehabilitation. And so we know, and as I've alluded to this already, that a lot of our patients, not dissimilar to Manchester, move around the system a lot for their treatment. And it's around holding that holistic approach along that journey. And that really is best sat within the primary care system. So this is our pathway in Cardiff and Vale. And as I say, we've got a collaborative starting across South East Wales, and Ridian is our anaesthetic lead for that collaborative. We're working under the headline of maximising outcomes from treatment, or MOT. And essentially, we're looking, this is for cancer or suspected cancer. So when the patient presents to their GP with red flag symptoms of cancer, we want, and we've been working in this space since August 2020, we want the patient to start their optimisation journey then. And as I alluded to earlier, we're not asking the GPs to do much more than signpost the patients. We've co-produced this with GPs. And as somebody was talking earlier, I actually had our local medical council text me. This is how keen they are to work with us about coming to their advisory board meeting in August. They want to help. They really do. But it doesn't just happen overnight. You have to work on these relationships. Essentially, what happens in our cluster where we're active in, we have patients referred to this optimisation service, and all patients will have their haemoglobin checked at that stage. And that's done in the GP practice by the phlebotomist. The problem we've had during COVID is clearly people weren't being seen face-to-face in GP practices. So that's been a rate limiting step for us, but we think we've covered that one off now. Similarly, they have the HbA1c checked, but I'm here to talk about anemia. Then, as Ridian said, patients will be, so that's our primary care stage of our pathway. And a lot of people will say to us, well, why are you optimising people who don't go off forth and have cancer? But actually, we know from the previous work we've done in this space that a lot of people have other benign conditions which need intervention, but also, and one of the things we were talking about earlier is how do you get your executive board to buy into this agenda? They need solutions to tackle prevention. I was with our new chief exec in Cardiff and Vale on Friday. Yeah, great what you can do for treatment, Rachel, but I want to hear from you about how we can tackle people when they're receptive to change and they're choosing to engage with the health system because they've got worrying symptoms. And this is why we've got recurrent funding now for our prehab service, because it's tackling people at the point of referral. In Cardiff and Vale alone, we have 15,000 people a year who interface and have diagnostic investigations for cancer symptoms. The vast majority of those will be given the all clear. But we are starting our optimisation then because we know that we can chip away with wellbeing coaches, with lifestyle changes, with nudging to improve their health and well-being. And you can see we're progressing through the system. So as the person's then confirmed to have a cancer diagnosis, we step up their intervention accordingly. So it's about being planned, sustained, and consistently through their pathway. I'm not going to go into any detail because you can see, I could talk about this all day, but I won't because of the interest of time. But how we're selling this to our GP colleagues, it's about maximising the benefit of the treatment they're referring in for or the diagnostic. And it's a jigsaw puzzle of which they're a massive part of this optimisation process. And I've got to say, speaking as I find, we have had great engagement from our colleagues. I'll stop there, Mike.
Brilliant. So there's one more question, which is not about haemoglobin, but which I'd like to ask everybody before we go. And it picks up on one of the points that that Scarlett raised. How many people routinely use tranexamic acid for major surgery, defined as more than 500 mils or say more than a couple of hours? Hands up in the air. And how many people don't? Or not going to admit it? Okay, so that's very reassuring. The reason I raise it is because there's a joint intercollegiate campaign from the surgeons, anaesthetists, physicians and National Blood Transfusion Service, because adoption is so low. So I suspect that we may have a relative group of enthusiasts in the room, but there's nice guidance. We've got a big randomized control trial relatively recently published in POISE 3. And if we're thinking about these pillars of blood management, that's probably a really important element. So don't be surprised if you hear a bit more about that in the coming months. And please encourage your colleagues who aren't doing it, and we know that because there's only about 25% implementation of tranexamic acid. Please encourage them to do it, because I think it's another piece of this jigsaw. So we are pretty much close to time. I'm going to ask last words from Scarlett.
Anemia, I'm going to say check for it early, but it's part of the same optimization as everything else. There's a finite number of things we can optimize, and we can optimize people.
Get in there early.
Yeah.
Jamie?
I would just say treat it as you would any other chronic disease like diabetes, heart failure, respiratory, bad COPD. Look at it in that same light and refer and deal with it appropriately.
I think it's just been a great session, personally. And I thank Scarlett and James for the discussion.
Thank you all for the conversation. It's been really, really, really good session. Thank you very much for a great day.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.